Okay, good morning. I'm Matthew, one of the education practitioners. On camera at the moment we have Beth, or Elizabeth. Can you introduce yourself?
Yeah, my name is Elizabeth Finney. I'm in cohort 2405 and I'm an apprentice ENT.
Good stuff. Also on camera we've got Rebecca, and Rebecca is the same cohort, but she'll be choking patient for this assessment. Beth, just to make sure you're happy that you're here for adult stepwise airway and foreign body airway obstruction.
Yeah.
These assessments cover CT16, CT16 and CT1. Yes, they do. Good. Any questions?
No.
No? Happy to continue?
Yep.
Lovely. What else was I going to say? Right, we'll do these assessments. Rebecca will leave after the choking bit and then we'll move on to the stepwise. What else we're going to do? We'll do a professional discussion at the end, but we'll do that on audio. Okay, so we'll bring this video to a close and do that as an audio. Your recovery position will be a separate video. I don't expect you to do CPR on this patient because that will be demonstrated on another assessment. Okay, and that's it.
Lovely.
Right, let's go. So, you're part of a crew, your mate is parking the vehicle outside, you've been called to a restaurant to somebody who is having lunch and they might be choking.
Okay, so first of all I'm going to don my PPE. There's no special precautions in place. I am going to put some gloves on just because I don't know the environment that I'm going into, if it's safe or not. But I am going to do a door approaching scene, looking for anything that I can slip, trip or fall onto, looking around the area as well, making sure there's no dangers, no hazards, and then going into the restaurant. I'm going to note my patient, having a look to see that she is in the universal choking position. I'm going to note her colour and note to see if there's any catastrophic hemorrhage as well. To see if there's a partial or a full obstruction of the airway, I'm going to ask two simple questions. Hello, my name's Beth, I'm from the ambulance service. What's your name? Are you choking? Okay, so I've established that the patient's now choking. So I'm going to do 5 back blows. Okay, so what I'm going to do, I'm just going to hold it. Can you put your hands down? Thank you. And just lean over for me. Lovely. I'm going to just protect the airway and place my hand here to see if anything comes out as well. With the palm of my hand, I'm going to do 5 back blows. Continuously looking to see if there was anything coming out. I can't see that anything has come out. Right, what I'm going to do, I'm going to do some abdominal thrusts on you. Okay, we need to try and get this blockage out. So, okay, just lean over slightly for me. Lovely. Checking again. There's nothing on the floor that I can see because the patient is still choking. I'm going to go ahead and do those back blows again. And still nothing out. Again with the abdominal thrust. Nothing has come out still.
Okay, so the patient becomes heavy and floppy in your arms and then falls to the floor. The obstruction is not dislodged. What I'd just like to ask you, is there anything, when you first approached, is there anything, you did a great approach, spoke to the patient, asked them if they were choking, is there anything you could have asked them to do at that point?
Cough, to see if they were able to cough. That would have indicated that there was a partial obstruction rather than a full obstruction. Perfect.
Okay, so patient on the floor is a continuation of the choking patient we've just done. And we can assume that the obstruction did not come out.
Okay.
And I'll let you manage this patient.
Wonderful. Okay, so I'm going to check the airway. I'm going to do a cross-finger technique. I'm going to check and see where that blockage is. If it is within my reach, I'm going to use my McGill's to grab that blockage. Cross-finger technique. I'm going to go in only as far as I can see and pull the blockage out. Now, if there was any fluid that I could see in there, is there any fluid?
There is a little bit, yeah. It looks a bit like blood and vomit type stuff.
So what I'm going to do, using my suction and my yanker, I'm going to set it to 200 and I'm suction as far as I can see for 10 to 15 seconds to avoid any hypoxia, and only going as far as I can see to avoid stimulating the vagus nerve, which controls the breathing for the patient as well. I'm not going to hold the suction in. Every time I suction, I'm going to pull out until that is clear of fluid.
Excellent. The airway now appears clear.
Okay, so I'm just going to check the C-spine. And there are no abnormalities. If there were any abnormalities, to maintain the airway, I'd do a jaw thrust instead. But this time I'm going to do a head tilt, chin lift, and look, listen, and feel for 10 seconds to check that breathing and see if there is a rest rate at all.
So the patient is breathing, and their rest rate is 14.
Okay, and I'm just going to check for a carotid pulse as well to check for the heart rate.
And they do have a pulse, and it's 100.
Wonderful, okay. I'm just going to open that chest just so I can check that there is still rise and fall, and I'm going to secure that airway now. So I'm going to measure my OP airway from the jaw to the incisors, check that that's measured correctly. We're going to invert, insert, rotate and locate that for the patient, making sure that that's being tolerated as well.
Yep, they're tolerating that.
And then we're going to measure the MPs from the nose to the ear, beveled edge to the septum. And we're going to straighten that as well so it slides down perfectly. That resistance. I would have placed lube on that as well. Beveled edge to the septum. There we go. And then I'm just going to look, listen, feel again, making sure that there's still breathing.
Good, they are breathing.
Lovely. I'm just going to check the rest rate again for this patient as well. They are breathing, so because they're still breathing, I'd put a non-rebreather mask with 15 litres on after checking JR calc. If patient wasn't breathing, however, for themselves, I'd then bag the patient. Doing this, I'd place the BVM over the patient's mouth and nose, doing a C and E grip. Head tilt, chin lift, looking for 2 rises and falls of the chest there.
Lovely. Good management of the patient, well done. Could you give me an S-bar, please?
Yeah, so we've been called to this restaurant for a patient that's been choking. Found a female that has been choking. We administered a total of 10 back blows and 10 abdominal thrusts. Fortunately, we weren't able to clear the obstruction and patient became unconscious. Once unconscious, I was able to clear the obstruction with my gills. Airway became clear, rest rate's 14, pulse is 100, and the patient is still looking GCS 3 at the moment. We have bagged as well.
Okay, lovely. What's your recommendation?
I recommend we go on a red standby to A&E. We monitor in case CPR needs to start as well.
Lovely, thank you. Okay, that brings us to the end of that assessment. What I'd like to do is just give you a little bit more for you to demonstrate for me. Okay, I'm just going to make sure this is on camera, so I can either move it to you or you're going to stand up. Right, so this is an infant under 1. We've already demonstrated how we manage a choking patient in an adult. What differences would you do on this patient, please?
Okay, so for a child under 1, we'd normally protect the head and we'd use 2 fingers to do chest thrusts rather than abdominal thrusts, and do 5 of them. And if there was nothing coming out, we'd then flip the infant over, secure that airway, and we can rest it on the arm so the baby's secure and do 5 back blows that way until the obstruction came out.
Lovely. And let's say we have a 6 or 7 year old. Are there any modifications you could think of for that kind of patient?
Yeah, if the 6 or 7 year old was a good size, I could be able to get them over my knee to administer the back blows.
Yeah, good stuff. Okay, any questions?
No.
We'll bring this to a close and then we'll do a quick PD on audio. All right, thanks.